Hi everybody, I have come up with again one more lecture on ventilator graphics after the huge demand from my students, and it's quite huge topic, and this is the reason I had divided it into three videos. It takes hell of effort to create such kind of videos for you, and I want support from you guys. If you could just like it and subscribe to my channel, the Critical Care Academy, and forward these videos to your colleagues so that it will motivate me to continue making the video, because this really takes time of a busy physician like me. These videos are not only for doctors, even for senior nurses, experienced intensive care nurses, and respiratory therapists, emergency physicians, technicians who have first-hand knowledge of ventilators. So all those people, all those health personnel who are working with the ventilators will get most of the benefit from these videos. So simply, ventilator waveforms can be divided into scalars and loops. Okay, so this is major categories, and scalars basically are the variable against time, and loops are basically the relationship between two variables. So we have three types of scalars: pressure, flow, and volume. As you can see on this screen of ventilator, upper one is pressure time scalar, middle one is the flow time scalar, and the last one is the volume time scalar. If you look at the pressure time scalar, there is a baseline, as you can see, baseline, and from the baseline there is the rise of the pressure like this, right? So which is called ascending pressure waveform. We are going to talk about this more in the subsequent slide. So pressure waveforms can be ascending, and other type is the square wave. So ascending pressure scalar waveform suggests volume control mode where peak pressure is observed. So there is a peak pressure here which is observed, and a slope steepness slope there. So this is the pressure time inspiratory slope. So this reflects the lung compliance. A steeper slope indicates the lower compliance. So, okay, this is very important information. So this scalar lacks plateau because of no respiratory pause. But when you put the patient ventilator setting on inspiratory pause, then it will look like this. So you would see a plateau here, and this plateau is basically going to tell you about the stiffness of the lung. So pressure at this plateau is the plateau pressure, which is clinically significant. So this happens during respiratory pause. When there is a PEEP, you would be seeing this kind of ascending curve. Pressure control mode, the pressure time scalar changes to square wave like this. It becomes completely square wave because of constant pressure. You can see in the whole inspiratory phase the pressure is constant. So this is the signature of pressure control mode. Now we are going to talk about a very important term which is known as slope, or ramp, or P rise. These are all same. So that refers to the speed at which the ventilator reaches the target or peak inspiratory pressure. Okay, so speed with which the pressure attains the maximum inspiratory pressure. So here it is 0. There is no steepness at all. But if you look at this, suppose pressure rises slowly, so there will be some P rise or ramp. So there is some ramp here, and this ramp is gradual. As you can see, this is called P rise 1, which is longer, little longer. Okay, and now compare this to this one, this another line, hypothetical line P2, where the rise is little faster, right? So this is faster, P2, P1 is slower. So here the P rise is shorter. The P rise 2 is shorter than P rise 1. So shorter the P rise, more steep will be the curve. So that can be manipulated on the ventilator settings. So what is the normal P rise? 0 to 400 millisecond is the normal P rise, and we select usually 150 to 200 millisecond, or 0.15 to 0.20 second, which is the normal P rise. Okay, shorter P rise is for the patients who wants more flow. At the same time, patient will feel air blast during inspiration because the pressure rise will be very fast. Suppose if you keep it slower, like 0.3 or 0.4 second, that will result in feeling of hunger. It will be very comfortable for the patient sometime, but suppose patient's demand of flow is higher, then patient might suffocate, they will feel air hunger. So it has to be set as per patient need. All right, and usual value is 0.15 to 0.2 seconds. So this is a very important point. Many people are not touching this knob or this button on the ventilator. By default it is 0.20 seconds, so that's good. No need to worry about that, but you can actually manipulate it. Looking at the pressure waveform, you can identify so many things: airway resistance, lung compliance, or patient ventilator asynchrony like auto-PEEP or flow starvation, late cycling, premature cycling. Okay, so many things. So let's talk about this. So to detect the auto-PEEP or intrinsic PEEP, usually intrinsic PEEP is detected on the flow time scalar, which is more sensitive than pressure time scalar. Sometimes in exam you may be just shown the pressure time scalar and asked what is happening here. So if you see this kind of pattern where the expiratory pressure drop is not complete, there is some pressure left at the end of expiration, and it is increasing with each successive breath. Okay, so it's not reaching the baseline and it is increasing also, then it means that there is some auto-PEEP development. But this has to be done when patient is on no external PEEP or zero PEEP. So for this you have to turn the PEEP button off, make it zero. If you see elevated baseline pressure, then there is some intrinsic PEEP. However, in case of ARDS, acute respiratory distress syndrome, PEEP cannot be turned off, because it will result in immediate alveolar collapse or de-recruitment of alveoli, which may be harmful. In that case, you have to look at the expiratory flow time graph, so which you will see later. Now, another sign which you can observe on pressure scalar is ineffective triggering, which is a common type of patient ventilator asynchrony. So on the pressure time scalar, look for small negative deflection or dips. Can you see dips here? Okay, dips before the elevation. So this is your ineffective triggering. So what is trigger? Trigger means patient create a negative pressure. Okay, and this negative pressure is sensed by the ventilator, and ventilator provides full breath. As you can see here, in this part there is some negative pressure here, and then ventilator provides full breath. But here there is some negative pressure, but the ventilator is not triggered. So this is called ineffective triggering. Why it's happening? Because still it is not enough negative pressure because of auto-PEEP. So auto-PEEP and ineffective trigger both are related. Okay, so there is dip or negative deflection in the expiratory phase, but there is no inspiration at all happening, and this is ineffective triggering. Again, one more example here. Negative deflection is the ineffective triggering. Usually it is above the baseline pressure. Okay, so obviously there is some auto-PEEP which is causing more pressure, negative pressure requirement by the ventilator as a trigger. So this occurs because patient must suck hard enough to overcome the internal trapped pressure, which is auto-PEEP, before ventilator senses their effort. Whenever there is auto-PEEP, there could be ineffective triggering. Okay, you have to look for it. There is a negative deflection if you think like this, but it's not below the baseline, as you can see here. Okay, it is touching baseline. So this is normal expression. But what is happening here? There is a bump, okay, in the expression. Immediately after ventilator cycles to exhalation, look for sudden upward spike. So there is sudden upward spike, okay, which is basically premature cycling. So premature cycling happens because the ventilator terminates the inspiratory phase before patient's inspiratory muscle effort has ended. So when patient still wants some more inspiration, okay, still patient's inspiratory muscle, basically diaphragm, in contracted phase, but ventilator has cycled off early, which is called premature cycling. So the patient continues to try to inhale against an expiratory valve. This is the problem, and that is why there is a sudden upward spike in the expiratory phase. So this is again a patient ventilator asynchrony. Again, another waveform, you look for this upward spike. Okay, so this is very typical of premature cycling. Patient continues to try to inhale against the expiratory valve. Another type of asynchrony, if you look at the pressure time scalar here, it should be constant pressure, but what is happening, there is bump or upward spike in the last phase of inspiration. So look for a sudden bump or upward spike in the airway pressure at the very end of inspiratory phase. This happens because patient's expiratory muscles are contracting against a closed inspiratory valve, causing a localized pressure increase. So what is happening here, the cycling should be occurring just here, but it is going to occur little later. Okay, so patient wants to expire, but ventilator is not opening the expiratory valve. Okay, so this is the example of delayed cycling. And remember that delayed cycling can result in intrinsic PEEP again. So there is a elevation of pressure time scalar, the increase in the pressure during at the end of inspiration. Again, here also there is a bump or upward spike. And if you look at the flow time scalar, this is flow time scalar, there is the auto-PEEP development. So remember that delayed cycling can result in auto-PEEP. Okay, sometimes you may see a scooped appearance of pressure time scalar, okay, in the volume control mode. So this is volume control mode, pressure time scalar. So this is kind of smooth. Here there is a scooped pattern, so which is seen in the flow starvation. If you see this kind of picture, the patient is having some flow starvation, which is again a type of patient ventilator asynchrony. Here patient's breathing effort or demand exceeds the flow the ventilator provides, creating a scooped pressure waveform or dip. As the patient pulls harder, especially in volume control mode, signaling patient distress and requiring adjustment like increasing respiratory flow to meet demand and smooth the curve. So in this situation, you need to increase the flow because the flow is fixed in volume control mode. It is more commonly observed in the volume control mode where the flow is constant and volume is also constant, right? So if patient requires higher flow, patient will try to inhale, but it will not be provided by the ventilator. Higher flow will not be provided, and that is the reason the negative pressure created here, the scooped appearance. Okay, so this problem can be solved by giving more flow or changing the volume control to pressure control mode. So as I said, if you look at the peak pressure and suppose peak pressure increases, high PIP, that is signaling the high resistance of airway in volume control mode. So high airway resistance is primarily detected on the pressure scalar. Is steeper, so this will become steep and sharp rise to the PIP. Okay, so the P rise will be steeper automatically, and definitely there will be increase in the PIP, and plateau pressure may be enormous. Okay, so this will result in wider trans airway pressure. Trans airway pressure is equal to PIP minus P plat. Always remember, trans airway pressure is the pressure to overcome the airway resistance. Remember that. Poor compliance, in this case, this is very standard kind of scalar where you would see the narrow or normal trans airway pressure and increased plateau pressure. So very typical of poor compliance. So poor compliance can be detected on ventilator very easily. As you can see here, there is a peak pressure, and immediately after peak pressure there is a high plateau pressure. If you look at here, the plateau pressure is quite high. Okay, about 28, and the patient is requiring PEEP of 17, means the patient's lung are really bad. This is the ARDS lung. So poor compliance means high plateau pressures, and sometime in exam you would be shown this kind of curve. Okay, the prolonged P plat. and examiner will ask you what is happening. So basically this is inspiratory hold maneuver. So answer will be that we are measuring the plateau pressure in volume control mode, and this is inspiratory hold maneuver which lasts usually from 3 to 5 seconds to calculate or to measure the plateau pressure. All right, so that's all for today. Thank you so much. In next session we are going to decode the flow waveforms, okay, in the second part of this series.